All right. So let's get things started this evening by introducing our speakers, Dr. Humaira Kadri and Jessica Sebastian, both with Ascension St. Agnes Maryland surgeons. So Dr. Kadri is a board certified complex general surgical oncologist, as well as general surgeon. He is highly experienced in all aspects of surgical oncology and general surgery. His areas of expertise include diseases of the skin, liver, bile ducts, pancreas, gastrointestinal tract, breast, endocrine organs, connective tissue malignancies, and metastatic malignancies. He performs procedures both open and minimally invasively using laparoscopy as well as robotics. Dr. Kadri was inspired to become a surgical oncologist when seeing patients with complex cancers who required a multidisciplinary approach to treatment. He understands that cancer patients are in a fragile state upon diagnosis and spends his time helping patients understand their disease and how best to help them. His goal is always to recommend the best surgical approach and multidisciplinary treatment to help cure a patient of their disease and improve quality of life. Dr. Kadri has published numerous peer-reviewed journal articles on cancer treatment and strives to apply the most recent and up-to-date medical information when treating his patients. Also joining us this evening is Jessica Sebastian, who works with Dr. Kadri at Ascension St. Agnes Maryland Surgeons. She's been practicing as a physician assistant for 12 years, and she began her practice in urgent care and has been working in general surgery for over 3 years. Jessica works in both the inpatient and outpatient settings and assists with a wide variety of surgical procedures. She gained her passion for medicine from her grandfather, who was a family care physician. She saw his compassion and dedication to his patients and wanted to provide the same quality service for her own patients. She's empathetic, dedicated to providing excellent care, and always makes herself available to her patients. So we're very excited to welcome Jessica and Dr. Kadri this evening. Thanks so much for being here.
Thanks
you guys
for having us.
Yeah, thanks, Kelly. So again, my name is Humaira Kadri. I'm one of the surgical oncologists here at Ascension St. Agnes. So we're part of a skin cancer team, and Jessica will introduce herself as well.
Yeah, so I'm Jessica. I'm the physician assistant with Maryland Surgeons. I see a lot of postoperative patients as well as acute cases. And as of more recently, Dr. Kadri and I have been working together to evaluate and treat various skin cancers.
Yeah, so we work together and we basically see patients and we take you through from the first diagnosis, from biopsy, all the way through treatment and what you'll need afterwards. And again, feel free to ask questions during the webinar. If something doesn't make complete sense, feel free to put it in the Q&A and we'll get to it either at the end or we can get to it separately afterwards. So we can just dive into the presentation now. So really this topic is understanding skin cancer. So what is skin cancer? Many people hear it and they say, well, what is this thing? So if you were to take a piece of skin anywhere on your body and put it under a microscope, this is what you'd see. So you would see a couple of different layers. You'd see the epidermis, which is the top layer. You would see the dermis, which is the layer below that. And then the subcutaneous fat or tissue, which is basically this white component here. Then the fascia, which is this thick lining that's here that covers over muscle. And then muscle is down below here. So within the epidermis are the main skin cells that we have that can go haywire from multiple risk factors, which we'll get into. So in the top layer, you have these squamous cells, which are these sheet-like cells that sit up above. In the bottom layer of the epidermis, you have these cuboidal cells called basal cells, which sit at the base. And then interspersed between that, you have the melanocytes, which are these pigmented cells that give you and I the characteristic skin color or skin tone that we see. Within that, there are also some small neuroendocrine cells, if you look here, called Merkel cells, and these are also interspersed at the base of the epidermis. Now, again, any one of these four cells can go haywire from multiple risk factors and can turn into something called a carcinoma or something invasive, or essentially you've got an abnormal cell that'll start to grow and start to invade through the epidermis into the dermis, and that's when we consider it an invasive cancer. So within that, there are different types of cancers of the skin. There are basal cell carcinomas, which are, again, these cuboidal cells, which turn into this, depth or growth of cancer through the epidermis into the dermis. There are squamous cell carcinomas, which also go through, again, the epidermis down into the dermis. And typically these two types of cancers do not go into the lymphatics. They're very rare, but can go. The risk factors are typically anywhere between 3 to 9% in the literature. But again, these typically stay within the area of the skin and do not go to lymphatics. Now, melanoma, on the other hand, which is again an overgrowth of the melanocytes, when it goes through the epidermis, it becomes invasive. And this does have an increased risk for going into the lymphatics and spreading. And we'll get into the reasons for why and you know what the biggest risk factors are for that. But at the same time, this we treat many times differently than basal cell or squamous cell carcinomas. Within a subset of melanoma, there's something called melanoma in situ, where there is an overgrowth of melanocytes that are in the epidermis, but only stay within the epidermis. So if you were to see only these melanocytes growing in this area of the epidermis, and they don't penetrate through the epidermis, we would call that melanoma in situ, and that's treated much differently, and also has a lower risk of spreading because it hasn't broken through the epidermis. Now, less commonly, we see Merkel cell carcinoma, but it is something to be discussed because it does have potentially worse survival outcomes due to the aggressiveness of the cancer itself. And again, these are these neuroendocrine cells that sit in the epidermal layer just at the base that are essentially linked with nerves. And you know, can also have the same risk factors which change this into, but we'll get into that into more detail. So how common is skin cancer, right? Many times it's talked about, but we don't realize like how common it is. And basal and squamous cell carcinomas are actually the most common cancer in the United States, right? To the point where, because they have such a low risk of death, when we'll go into that, they're not even really well reported in the data, right, that's there. So we're estimating that there are around about 5.9 million basal and squamous cell carcinoma cases per year that are diagnosed in the United States. When you look at the next highest cancers, like prostate in men being around 200 something thousand and breast in women being up close to almost 300,000 cases per year, this is astronomically higher, right? But the good thing about both of these cancers is that the 5-year survival is also quite high. It's about 99%. So with that information, you say, okay, well, it is a cancer, but you know, when you do get diagnosed with it, you're not considering it, okay, it's a death sentence, which is actually a good thing to understand. Within that subset of skin cancers, though, there is melanoma, and there are approximately 100,000 cases per year based off of the SEER database. The 5-year overall survival with this is around 94% when you look at it. So it is still good survival. However, this includes all stages, right? So stage 1, stage 2, stage 3, and stage 4, which has spread to other organs. And so you do have to take that with a grain of salt, and we'll talk about other risk factors and potential causes of it. And then finally, Merkel cell carcinoma is actually quite a rare cancer. There's only about 3,000 cases per year in the United States. The survival for this is actually much lower than melanoma. And again, this is all comers, all stage. It's about 70% when you compare it against melanoma or all the other skin cancers. So it is one that is a lot more aggressive than the others. So what are your risk factors for skin cancer, right? It's what we know, right? We all kind of hear these things. We say, oh, don't go out in the sun too long. You're going to get burned. You're going to have all these things. So typically, as we know, it's long periods of unprotected sun exposure. And what you're getting is the UV radiation from the sun. And we'll go into this in detail, but there's UVA and UVB radiation. That itself damages the skin to the point of where it creates mutations in the skin and then potentially leads to a cancer. If you have a history of multiple sunburns, right, you're technically getting the UVB radiation when you're getting sunburns. That itself promotes you to have an increased risk of cancer. Fair skin. So if you're Caucasian or you're albino, all of these reasons for potentially having skin cancer are there, and this just promotes your increased risk for it when you do have fair skin. Smoking itself is also a risk factor for skin cancer. Now, many times we're not looking at the effects of smoking when we're younger. Many patients just kind of ignore it and say, oh, it's fine. But when you actually look at a patient who's had long-standing sun exposure history and smokes, when they get above 50, you can tell that their skin has been damaged from long-standing sun exposure and from smoking. And you compare to patients who have not had unprotected sun exposure and long periods of it, or they don't smoke, you can see that their skin looks a lot better. So if anything, if you were to say like, I can't stop smoking, and it is a difficult thing to stop, one big thing to say is like, hey, I don't want to look older than I am when I get older, as just a caveat to this. But again, the toxins that are created and the carcinogens that are created from the cigarette smoke and everything else that you inhale can trigger an increased risk of skin cancer. Family history is also a very important component. Many times your genetics kind of dictates how your body will respond to sun. Some people, if you have darker skin, you're out in the sun all day unprotected, don't develop a skin cancer, right? But if you have fair skin, you're out for 5-10 minutes a day, you have such a high risk of developing skin cancer. So you do have to look at your family history, which includes your genetics, to say like, all right, do all of my family members get some type of skin cancer, and how can I protect myself against this? Radiation itself is also a risk factor. Now, typically this is isolated to those who, are X-ray techs or those who are around radiation. But an important thing is to shield yourself from the radiation if you don't need it. Chronic inflammation can also lead to skin cancers, right? So many times patients will have wounds that are there that have not been treated well, or just sitting there, and they get infected and they're chronically inflamed, and treatment there is not going well. At times, there can be a risk of skin cancer development in the edges that we'll see. So treating chronic wounds is always important, and the chronic inflammation that's caused by it is what you need to reduce. And then finally, a weakened immune system, which sometimes is unavoidable, is also a risk factor for skin cancer. Let's say you have an organ transplant and you are taking immunosuppressants that promotes you to have an increased risk of skin cancer. Let's say you're getting treated for inflammatory bowel disease. You're getting treated for something where you have an autoimmune reaction, which you need to suppress that by suppressing your immune system. That unfortunately increases your risk for skin cancer. Now, it's unavoidable because you don't want that other component of your body to create more problems. But at the same time, you do need to be aware that that is a risk factor for potential skin cancer. So let's go through the different types of skin cancer, just like picture depictions. And, you'll see that these all look very similar, right? You'll say like, well, all of them look the same. How can we delineate it? You really can't at times delineate things, because at times there's no real true pathognomonic things other than a melanoma. You see like a pigmented lesion or a mold that looks abnormal. That's maybe one way you can look at it, but even melanomas can be non-pigmented, and they can be just looking like these lesions as well. So this is where many times a biopsy becomes essential when you look at something concerning. So let's start with basal cell carcinoma. Let's say you have a lesion that's there and you're concerned about it. And basal cell carcinomas can look like a flesh-colored bumper mass. Typically, it can also be an ulcerated wound that doesn't heal, right? So you've got a wound that's there that's never healed, or bleeds and causes problems. If it doesn't heal over some time period and you've done a really good effort to avoid infection in that area and treat it, that ulceration could be a skin cancer and should be evaluated and biopsied. You can also have a lesion that looks dark pink or colored like a scar. That can also be a basal cell carcinoma. Now, again, the risk of lymphatic spread is very low in basal cell carcinoma. Typically, I'll quote around 4 to 6% or even less, like really around 3%. But the literature is kind of mixed since there's not a lot of good data, and they say it can be up to 9% in certain situations. But for the most part, this is a very, very low risk of lymphatic spread. Squamous cell carcinoma, you might look at these photos and say, hey, they look similar to the basal cell carcinoma photos. They do. They are very similar, and it is difficult to completely delineate it. And now with squamous cell carcinoma, you might have a little firmer nodule. You might see an elevated growth from it with a little central depression. You might see a scaly red mass that's there. And again, non-healing wounds can also have squamous cell carcinoma develop in them. Again, the risk of lymphatic spread in this is also lower. It is a little bit higher than basal cell carcinoma, let's say about 4 to 6 to 7%. But again, the literature kind of ranges with both of these between 3 to 9%. Now, getting into melanoma, right? We all kind of hear about this all the time, and we know that moles that look abnormal should be evaluated. But when you look at a melanoma, we're taught this in med school, that you want to evaluate a mole or concerning skin lesion by looking at the ABCDEs of that lesion, right? So you want to look at a lesion, and this picture here depicts kind of the different changes of this. You want to look at the symmetry of the lesion or the asymmetry, right? Does it look symmetrical on both sides, or is it asymmetrical? Does one side, is it a nice, well circumscribed thing, or is it a nice circle, or is it jagged and have all these weird areas to it? Asymmetry puts you at an increased risk of this being something concerning. B, the border, right? Look at the border of a lesion. If it's a well circumscribed mole that looks nice and circular and doesn't look like it's had any problems or changed over time, great, the border looks fine. That's good. But if the border starts to change or becomes irregular, that can be a concerning thing for skin cancer. Looking at the color, a generalized statement is that heterogeneity in color you don't want to see. You want to see a well, similar colored lesion that's there. You don't want to see one area of very dark spots and lighter spots, or light brown or dark brown. That to me could suggest that, hey, maybe there is an area of growth of concerning melanocytes that could be a cancer. You also want to look at the diameter. So typically we say that the tip of a pencil eraser is about the size that if a mole gets to being about this size or bigger, you get concerned that that could also be a melanoma. Now, a melanoma can be smaller in size than that or bigger in size than that, but it is just kind of a characteristic to understand and say like, okay, if it starts getting big, then hey, that's an important characteristic to look at and talk to my doctor about. And then finally, evolution, right? This is the biggest thing that's a component of this, right? So let's say you've had like an abnormal looking mole for your whole life, right? It's unchanged. It sits there. It looks weird, but it's been there for 50, 60 years of your life, right? The likelihood of that becoming a melanoma is pretty low if it hasn't changed over time, right? But at the same time, again, it should be evaluated and seen. But just be aware that things that change drastically over time, like you had a mole that looked fine, and then all of a sudden now it's like projecting these little lesions outside, or it's turning irregular, that is a very concerning lesion that should be evaluated. And now melanoma itself has an increased risk of lymphatic spread compared to basal cell or squamous cell carcinoma. And when we diagnose melanoma, we look at the depth of invasion of the cancer. So when the depth gets greater than 0.8 millimeters, which is very, very tiny. If you were to think about 0.8 millimeters, 1 millimeter is literally like almost like a sliver, close to like a couple of sheets of paper. So when the melanoma gets thicker than about 0.8 millimeters, you have about a 10% risk or chance of having lymphatic spread or a positive sentinel lymph node. So at that point, we do recommend patients undergoing sentinel lymph node biopsies for diagnosis and potentially treatment. And then finally, Merkel cell carcinoma. Again, this kind of looks similar to basal cell carcinomas and squamous cell carcinomas and even melanomas when they're like non-pigmented. But again, it's a fleshy, shiny nodule that's there. Typically, Merkel cells actually look more red if you were to really want to delineate things, almost like a raspberry if you look at it. So that's like a fleshy mass that's there, but even then it's very hard to delineate exactly. These are more likely to be found on the head and neck region or the trunk of the body, but again, I've had Merkel cells on the extremities. So there's no real exact thing to say like, oh yeah, that's there because it's there or that. Now, the one interesting thing about Merkel cell carcinoma is it is linked and likely caused by Merkel cell polyomavirus. Now, when people go through and evaluate the skin lesions after excision, they looked and saw that about 80% of patients who had Merkel cell carcinoma were infected with this virus. So there is some correlation between this virus and skin cancer. Now, many of us get this virus as a young adult or even older adults. So again, not only is it just the virus that triggers it, but again, you've got the radiation changes or the risk factors that you can develop that can trigger this to developing a skin cancer as well. So it is something just to be aware of. And now in Merkel cell carcinoma, the risk of lymphatic spread is always important and must be evaluated. Because it is more aggressive technically than even a melanoma, we do need to evaluate most of these lesions with a sentinel lymph node biopsy. And information off that sentinel lymph node biopsy may change, number one, add additional surgical treatment, radiation, or even adjuvant therapy with immunotherapy or chemotherapy. So let's say you develop, God forbid, a concerning skin lesion, right? And you say, oh, something looks weird. I got to take care of this. What should you do, right? Ideally, many of us think, okay, let's go see our dermatologist first, right? But what happens if you don't have a dermatologist, or what happens if your dermatologist is booking out for 3 months, right? It is difficult in this area. And I've had the difficulty of having my patients get a dermatologist where they're booked out so far that if there's something that is concerning, it's really tough for them to get you into an appointment. So in those instances, I say, try and see if you can see your dermatologist. If you cannot, go see your primary care physician and have them evaluate the lesion, right? They might say, okay, it doesn't look that concerning, but I do think you need to see somebody for this. And in that situation, they may refer you to a surgeon or a surgical oncologist and say, hey, can you biopsy this? Can you evaluate this quickly? Because I'm not sure, what it is, right? Especially if they can't reach a dermatologist. So when we determine if a lesion does need a biopsy, what types of biopsies do we do? There are different types of biopsies that we can do, and there are kind of broad categories of this. There are biopsies that are called incisional biopsies, where we take a piece of the lesion itself and take it out, versus excisional biopsies, where we take the whole thing out and remove it. Now, incisional biopsies can be, shave biopsies, where you take out most of the lesion, or you're just basically, as you see in the top area here, just shaving the top part of the lesion. You may be leaving some lesion behind in the base or in the peripheral region, but a shave biopsy can be performed and is most of the time performed by a dermatologist. A punch biopsy can also be performed, which may take a piece of the skin lesion and normal skin to compare, what things look like. And in my preference, punch biopsies are many times preferred, especially in melanoma, because it gives you a good understanding of the depth of the lesion. And then finally, you could do an excisional biopsy, where you cut out the thing and send it off, and then see what it is. Now, the biggest component of an excisional biopsy is how are you going to treat it? And we'll get into margins of lesions and what you should do. But when you do decide to do an excisional biopsy, make sure the person who is doing it understands that, hey, they might say, hey, I'm taking this out with the concern that I'm not worried about this lesion. It's probably fine. It's a benign mole. But if something needs to be done, you may need to have a bigger excision after that. So now you've got the lesion out, and now the person who took it out will get a pathology report, right? They will take this pathology report and they'll go over things with you. They'll say, okay, what is the diagnosis of the skin lesion, right? And there's a broad category where they'll say, is it benign, which means that it has no risk of spreading and it's not concerning and it's something to not worry about, or is it malignant, which has some concern, obviously, for spreading, and there is a risk of having problems with it, and you do need further treatment. And this biopsy report will give you more information, and the person who did the biopsy should discuss with you the next steps in treatment. So now let's get into the treatment if you have any of these biopsy proven skin cancers, right? So if you have a squamous cell or basal cell carcinoma that's biopsy proven, the gold standard treatment for this is something called a wide local excision. Now, a wide local excision essentially means basically resecting the lesion with about a 4 to 6 millimeter margin from the edge of the biopsy. And this resection margin is shown in data to be adequate to remove the entire lesion and not really require you most of the time to have another re-excision if the margins are positive on final pathology. But what you'll do is you'll measure the lesion, and what I do is if it's a shaved biopsy site and it's a scar, I measure from the scar of the biopsy site, especially if the margins are positive, and then say, okay, well, I'll measure 4 to 6 millimeters from each side of it, and then it basically creates a circle for the most part. Now, you could say, all right, well, let me excise the circle. The problem with closure of the circle is that you would create these two little dog ears in the end. So the only way to really close it nicely in an easy fashion is to perform something called an elliptical excision, where you basically make an ellipse and then essentially cut that portion of normal skin around that area, which would be sent as margins, and then close that primarily. So sometimes when you say, I just had a 1 centimeter looking lesion, why do I have like a 4 or 5 centimeter scar? Many times it's because of that requirement for the elliptical excision to remove the cancer in total because of the margins. Squamous cell and basal cell carcinomas typically do not require sentinel lymph node biopsy. In my practice, and what I do is I do an intraoperative pathology evaluation. So while you are undergoing the excision, I will send that specimen to the pathologist. And in about 20 or 30 minutes, they will look at the edges and freeze the margins and then tell me with about a 97% accuracy that, hey, the margins are negative. You can, close with whatever way you need to close. And to me, that basically allows you to avoid an extra operation that you wouldn't need if, God forbid, you didn't have, immediate pathologic evaluation and, the margins were positive. So it is very similar to Mohs surgery as well, in which the dermatologist many times is also evaluating the slides when they're sending those little margins off of things. Now, reconstruction techniques for this, typically we can get away with primary closure and doing that elliptical incision and then cutting things out. But there are times when these lesions are on difficult areas of the body, like the anterior part of your shin. If you feel the skin there, there's almost no give or movement for the most part. You may require a skin graft in that case. Now, if the lesion is very big or it's in an area where we can't even do a good skin graft, then many times we may need to perform a rotational skin flap or a free flap to close that area. Now, if God forbid you have a very large skin lesion, like let's say, I've had some patients with very large skin lesions over their entire scalp, and it's a large basal cell carcinoma or a large squamous cell carcinoma, that if we were to excise all of the skin on your scalp, it would be very morbid, right? You'd have a huge wound on your scalp and it would be, pretty miserable to deal with, not only to say taking the skin graft for that and covering it, it just seems a lot more cumbersome. So in that situation, radiation can also be used to treat these skin lesions, over a large area, or if a patient is so sick that they cannot undergo surgery, radiation can also be an option. Melanoma also includes a wide local excision, but we are also including typically a sentinel lymph node biopsy. So we would include a sentinel lymph node biopsy for any tumors, again, that are 0.8 millimeters or greater, right? And the margins of resection in melanoma are bigger than basal cell or squamous cell carcinoma. They're typically anywhere between 1 to 2 centimeters. Now, depending upon the location and depending upon the depth, we either recommend you undergo a 1 centimeter, excision margin or a 2 centimeter excision margin. And when you think about a 2 centimeter excision margin, that essentially turns the excision margin into something like this. So a circle would be about this big, and now your scar becomes, quite large. So with 2 centimeter margins, we are limiting those, if the tumor looks aggressive or there are certain characteristics on the pathology report that are necessary to say like, okay, well, we need to remove 2 centimeter margins. And if it's in a favorable location, like if it's on the back, that's much easier to do, or if it's on the chest, it's a lot easier to do than if it's on a leg. There is some newer data that's accruing right now, that there's a trial that's almost finishing accrual that's looked at 1 to 2 centimeter margins for even thick melanomas and in intermediate and thick melanomas. And right now it seems promising that 1 centimeter margins are probably the way things are going to go. But again, that data will not come out until 2025. So right now we're kind of doing a case by case basis based off the patient and their pathology report in terms of the margins. Now, sentinel lymph node biopsy, essentially what that is we need to detect the first draining lymph node that is coming from a patient's tumor, right? So typically what I do in my practice is dual tracer technique, where the time before the operation, you'll come in, let's say about 45 minutes before, an hour before, you'll be seen in the with the radiologist, and they will inject a radio tracer in around the skin lesion that you have. So around where the melanoma is, they'll inject a tracer, and that will travel to the first draining lymph node. While you're asleep intraoperatively, then I will inject a blue dye, typically isosulfan blue, into that region so that there are 2 markers of finding the first draining lymph node that's there. And then we'll typically use a radio tracer and the dye to go and find where the location of the lymph node is and then remove it for evaluation. Based off of, again, the lymph node, if it is positive, we can discuss the next steps in treatment. But what's happened now in a lot more newer literature and research, essentially many times we're monitoring positive lymph nodes rather than going and doing a completion lymph node dissection. But again, all of this is patient dependent and a lot more risk factors that we need to talk about if, God forbid, something were like that to happen to you. Melanoma in situ, again, we talked about that, where it's melanoma cells that are cancerous that are staying in the epidermal location and have not gone through the epidermis. Those only require a wide local excision with 0.5 centimeter margins, and you do not need to do a sentinel lymph node biopsy for those. And then finally, Merkel cell carcinoma, it's performing wide local excision like a melanoma with 1 to 2 centimeter margins, but also mandatorily always performing a sentinel lymph node biopsy. And the reason, again, for this is that in Merkel cell carcinoma, there's not a lot of research and not a lot of data. And typically, we don't really know really good margins based off of the size of a Merkel cell or what to do. And a lot of it's kind of dependent on location. So if there's a large lesion that's on your face, that's in a very, a significant spot, obviously we're going to want to try and minimize the amount of excision that we need to but we also want to clear the cancer. So it is important to kind of go based off of pathology reports and case by case basis. But every one of these cases does require a sentinel lymph node biopsy. So we would, again, dual technique tracer, send the tracer around where the skin lesion is, find where it is, and then remove that first draining lymph node. And the reason this is so important is that data for Merkel cell carcinoma suggests that most of the time, if God forbid the lymph node is positive, we will likely need to do either a completion lymph node dissection or adjuvant radiation to treat the area. And then there is further discussions on adjuvant treatment, which means treatment after the excision for immunotherapy or chemotherapy, which would be a bigger discussion if that were to happen. So you undergo surgery, you have your wide local excision, you possibly have a sentinel lymph node biopsy depending upon the cancer that you had. Now, what do you do postoperatively, right? You go see your surgeon and they'll see you and they'll say, okay, we got a final pathology report. Let's go through it, right? These are some components that you want to know that will be discussed with you, right? Is there residual cancer there, right? Is the cancer still there? Because we'll go into some cases where the cancer may not still be there, even though it was said to be there on a biopsy result. Number two, are the margins clear, right? Have the margins been completely removed and there's no more residual cancer in that area? Number three, if you require a sentinel lymph node biopsy, is it negative? Is it positive? This is an important, component of information to decide what to do for adjuvant therapy or therapy that's done after the excision. And then, do you need additional surgery? If the margins are positive, do we need to go back in and cut more stuff out, or do we need to go take out more lymph nodes? This is all a component that will be discussed with the pathology report. And if it is needed, you may need to be referred to a medical oncologist or a radiation oncologist to further treat things. So you might ask, okay, some patients will say, well, can't my body just fight the skin cancer on its own? Like maybe it might be able to kill it itself. And what'll happen is in some patients who have basal cell and squamous cell carcinomas more typically, what will happen is you'll have a biopsy of a lesion and it will come back, squamous cell carcinoma, all the margins are positive, right? Then we'll go through, we'll perform the wide local excision, and the final pathology report will actually show no residual tumor at all. So patients are confused by this sometimes. They say, hey, what's going on? Like there was cancer there in the biopsy results. Was that wrong? And did I have to have an unnecessary surgery? So the biopsy was not wrong. Right? What the pathologist is seeing was residual cells. But essentially what happens is your immune system kills those residual cancer cells that are there. So in understanding this, like you, I, all of us are making cancer cells throughout our body every day, right? We have cells that are turning over quickly and our body is a machine and it itself does make some mistake copies of cells, right? And the immune system is very good at targeting these cells and saying, okay, this one's messed up, mark this for destruction, let's get rid of it, let's throw it away and destroy it. But there are times when the body, number one, gets overwhelmed by a significant amount of cancer cells, whether you've had an increase in risk factors from smoking or sun damage or whatnot, that the body gets overwhelmed and misses some of these cancer cells. Number two, your immune system could be compromised or suppressed, and now your body can't have its immune system work well to kill any of these residual cancer cells that develop. Or as you get older, your immune system just doesn't work as well because it's, it becomes older and is like a machine and slowly is not as effective as it used to be. So what happens is one of these cancer cells, slips through and is, cancer is very good at evading the immune system. It'll put, these carbohydrate moieties on the top of the cells and say like, no, I'm a normal cell. Don't mess with me. I'm good, right? It'll say, hey, I'm Bob, you know me, right? And the immune system will go to it and say, well, something's not perfect, but I'm not sure, but yeah, you meet all the criteria of being fine. Okay, fine, go ahead, go live your life, right? And your immune system checks your cells every day, and it'll say like, okay, well, that's still Bob. We know Bob, it's fine, right? And the cancer is allowed to just grow in your skin as needed, willy-nilly. It doesn't even care. It's just growing and living its life, right? And what happens in a biopsy, because we see the lesion, it's grown, it looks concerning. We'll do a shave biopsy of the skin lesion. And if it's a cancer, all of a sudden now there's a big cut there. So your immune system will send all of the cells for healing to that area. You have increased blood flow, you have increased cells that are there from your immune system that are healing that area. And the immune cells say, hey, wait a second, this thing that we thought was Bob and our friend is actually cancer and it's been growing there all along. And essentially, it almost turns into a crime scene where the body says, all right, we got to clean up all of this stuff and get rid of all these residual cancer cells. So what will happen is that your body itself will kill those residual cancer cells with your immune system. So that's essentially something called spontaneous regression, where the tumor itself will basically go away from your body itself. Now, the biggest caveat of this is that we don't know who will develop spontaneous regression, right? It's very difficult to determine if somebody has an increased risk for having that or a lower risk for having that. And so a lot of it is that I treat my patients like they're my family, right? Or like they're me, like what I would want. So if like you were my mom, I would say, you know, maybe you should have this removed. Or if it were me, I wouldn't be able to have the anxiety of saying like, is there residual cancer left? Do I know if it's there or not? Maybe I need to have it out, right? But I do have some patients who say, look, you know, I am okay with the way things are. You know, the scar looks fine right now. I don't see any residual lesions. It doesn't look like that. You know, I'm willing to be monitored, but I don't have time, or right now is not a good component of my life to be able to have this big excision that requires a skin graft or requires a lot of treatment for reconstruction. You know, at times I will have the discussion and, you know, we may not do surgery immediately. We might say, hey, let's just monitor things. And it's kind of like a dynamic, you know, monitoring or surveillance of this lesion. And I can give you an example. Like I have a 95-year-old patient who has a large squamous cell carcinoma on her leg, who, you know, her husband was sick. She also had multiple medical comorbidities, was on blood thinners, all of these other things. And essentially she was like, look, I don't have time for this. I need to take care of my husband. And I said, you know, absolutely, that's the most important thing right now. Because that is what's important in your life at this time period. And I'm happy to help you and monitor this, you know, as you go through this. So, you know, each one of these discussions are always, you know, each patient is a little bit different and each patient has different preferences. But I always give my suggestions and I say, hey, I'm happy to go whichever way you'd like to go, but it all kind of depends upon you continuing to monitor, or we're going to remove the thing so that we don't have to monitor it specifically for that lesion itself. So, you know, again, there's no good randomized control trials for this also, which you would say like, okay, well, I have a 50% chance of it having spontaneous regression, or a 5% chance, or a 10% chance. I am trying to create a randomized control trial here, which may be multi-center, but again, there's a long time point between us getting data for this. So again, this is kind of dynamic discussion with every patient that we have, and we kind of say, you know, do we need to have this removed right now? When do you want to have it removed? Is there something coming up in your life that you can have it removed? And, you know, it is a dynamic discussion because, again, this occurs more frequently in basal and squamous cell carcinomas. But again, remember, your 5-year survival for this is 99%. So even if we wait a little bit, you are unlikely to have lymphatic spread, and it's unlikely for it to kill you, right? Now, the discussion is different for melanoma and Merkel cell carcinoma. Obviously, I'm more a proponent to saying we need to do surgery as soon as possible rather than kind of monitoring it. So that is also another component of that. So now, you know, you've heard all about this. Maybe you're scared to say, okay, well, I have all this potential for skin cancer. I've got family history for this. What do I do? So what can you do to prevent skin cancer, right? We all kind of know a lot of basic things about it, right? You know, the biggest thing is protecting yourself from ultraviolet radiation, right? That's the utmost primary component, right? Number one, using sunscreens, right? And we'll go into that, the specific types that you should use in the next slide. Protective clothing is very important, right? If you know you're going to be out in the sun, right, make sure that you are wearing protective clothing. You know, obviously, if you can avoid it, right, the peak sun hours are between 10 a.m. and 4 p.m., right, where you have the strongest sun rays and the strongest amount of UV radiation. If you can avoid being in the sun between those time periods, let's say you go and work out from like 6 a.m. to, you know, 9 a.m. or something, or you come home and work out between like 5 p.m. and 9 p.m., right? And those are the time periods that would be more preferred to reduce your risk from having increased amounts of UV radiation. But, you know, wearing protective clothing, if you have to, like, let's say you're a construction worker and you're out every day sitting on there, you know, fixing roofs or doing whatever you're doing, you know, taking efforts to put on sunscreen and wear protective clothing are very, very important. That's why most of the time you'll see roofers like wearing long sleeve shirts, because you'll say, man, it's so hot. But at the same time, they understand that if they don't protect their skin, they develop sunburns and potentially have an increased risk for skin cancer. And again, avoiding tanning beds are always important, because you don't want to be doing something that's just triggering the UV radiation into your body over and over again. Other avoidable risks, again, avoiding and stopping smoking. That itself can reduce your risk for skin cancer. Avoiding unnecessary radiation, especially if you're working in an area with radiation, protecting yourself from it, avoiding it if you can. And then really treating chronic wounds, right? Treating chronic inflammation and chronic inflammatory wounds on your skin is also very important, because that can reduce the transition of the skin cells in that area from being normal benign skin cells to turning into a cancer. So now, if you go to Target or Walmart or CVS or wherever you're going to go and you try and find skin sunscreen, you will see 50 or 60 or 70 different types of sunscreens. And it's very confusing, right? Many of us just say, like, I don't know, just get a sunscreen, get the one that's cheaper, get the ones on sale, right? Many times we're doing that. But, what type of sunscreen should we use, and what sun protection factor, SPF, should we have, right? So what this sunscreen does is it protects your body from the UV radiation rays from the sun. And you have UVA rays, which are long wavelength rays, which basically cause tans and actually cause aging in skin. When you see somebody with wrinkled skin, typically that's from UVA rays. Or UVB rays, which are short wavelength radiation rays that cause typically the sunburns. And they're, basically burning out or destroying the short epidermal layer from these wavelength rays. Now, what you really want to look at when you're buying a sunscreen is you want a broad spectrum sunscreen, which means that it covers both UVA and UVB rays. Because if you're just seeing a sunscreen that says SPF 15 but does not say broad spectrum, it is only covering UVB rays. And both UVA and UVB rays can increase your risk for skin cancer, even though UVB technically are the ones that have a slightly increased risk of developing skin cancer due to the burns. But when you look at your SPF, right, you're going to say, all right, so what do all these numbers mean? Because it doesn't correlate directly to how much, protection you have, in the sense that like 100 SPF isn't 100% protection and 15% isn't 15% protection. So SPF 15 blocks about 93% of UVB rays. SPF 30 blocks about 97% of UVB rays. SPF 50 blocks about 98%. And then SPF 100 blocks about 99%, right? So when you're looking at buying sunscreen, the most important thing that many people forget is that you want broad spectrum, and then you do need to reapply this sunscreen every 2 hours, right? That's the one fallacy that a lot of people make and say, like, well, I put on SPF 100, but I put it on once in the morning, right? It's not going to be as effective as you applying it every 2 hours or so, especially if you're out in the sun for long periods of time, or at the beach or some area where you're going to be in the sun a lot. So I would say, sometimes people say that the sweet spot is around 30, right? Where you're at 97%, and cost effective wise, right? Let's say SPF 30 is like $5, but SPF 50 is 15, right? Cost effective wise, you're going to be using a lot of it because you're going to be applying it every 2 hours. I would much rather you apply it every 2 hours and use SPF 30 than get SPF 100 and apply it, once a day. So that is just a component to understand when you are choosing your sunscreen SPFs, like what to choose. Now, what should you avoid, right? So newer sunscreens are chemical-based protectants. Something called oxybenzone is used in the newer sunscreens. Now, more recent data, which is a little bit mixed, has shown that these oxybenzones in animal models, right? So in rats and other animals, it can cause skin allergies, it can cause cancer, and it can cause hormone issues in these animals, right? So while oxybenzone sunscreens are easy to apply, they kind of just absorb very quickly, they're really easy to put in, there is some mixed data on it, right? So the FDA itself has not, recommended against it. They're still saying it's safe for humans. Don't worry about it. But at the same time, this newer data is coming about that's saying, hey, these things can happen from this, and just, to kind of be aware that it happens in animals. We still need more studies and findings in humans, but we still don't know yet if it creates any problems. So for me, if I were to just avoid that, I typically prefer mineral-based sunscreens, which are the old school, zinc oxide sunscreens that we've known, day in and day out, right? If you remember, right, we used to see the lifeguards out there and they put this like white cast sunscreen over their nose that's there and it protects their nose. That's zinc oxide sunscreen typically. The challenges of zinc oxide sunscreen is that it is really difficult to sometimes rub in and go away, and it creates almost like a white sheen over your face. So some people may not like that. Now, if you do rub it in enough, it does go away over time, but it does take like an extra minute or two doing that, versus the oxybenzone sunscreens, you just put them on and you're done, right? But in the end, right, wearing sunscreen is more important than not wearing sunscreen, right? So if you were to say, well, I can't use this mineral stuff, it's miserable, it makes me get so annoyed at it, I can't sit there for 2 minutes rubbing my face. I'd rather you say like, I'm not going to use sunscreen because I don't want to get the oxybenzone risk. I'd rather you use the oxybenzone and protect yourself from the harmful rays, because there isn't really any good data in humans right now to say that, it does cause problems. So just understand that protecting yourself against, UV radiation from the sun is more important than not protecting yourself. And again, look at each one of these sunscreens and discuss like, okay, this is what I'm going to use because of this. And, look at your budget, look at what you need to use, and don't forget to reapply every 2 hours. One big component though of all of this, right, is we're saying, okay, the sun is so bad, it's got UV radiation, it's like ruining everything, right? And the sun itself now has become vilified, right? It's become this thing that it's creating all these problems. And we say, stay out of the sun, don't do anything in the sun, you got to protect yourself, wear a hat, do all this, right? The problem is that now we're all becoming vitamin D deficient because of the lack of sun exposure that we have. And studies and data have recommended that about 15 minutes of unprotected sun exposure several times a week is usually sufficient for adequate vitamin D formation. And this is unprotected sun exposure, meaning you cannot put on sunscreen in these areas. So if you're going to go out and, your back or your arms, do not put sunscreen on there for 15 minutes and get some of the sun that converts and creates some of the vitamin D in your skin for your body. Now, there is a caveat to this, right? You do have to evaluate your risk for skin cancer. If you have extremely fair skin, if you've had a lot of long-standing sun damage from the sun or from tanning, or you have a really strong family history of developing skin cancer, you may not want to do this 15 minutes of unprotected sun exposure every day or every other day. And you may want to consider getting vitamin D from your diet, or in supplements, right? And vitamin D2 is typically from plants. Vitamin D3 is typically from animal sources or what our body makes. So just be cognizant of that, so you're not just throwing yourself in the sun and saying, no, it's okay, I'm getting vitamin D. That may not be the case in some patients. And, really newer data has shown that lower vitamin D levels are linked with multiple issues. Like you can have autoimmune diseases from low vitamin D, you can have osteoporosis, you can have heart issues, cardiovascular disease, and you can even have cognitive impairment, which means that your memory is not as good. You're not as good at understanding things. And I don't think any of us wants that. So one of the most important things, okay, you've God forbid had a skin cancer, you've got to treat it, it's all done. You say, okay, I'm good, thank God it's gone, right? Now, what do you do, right? The most important thing is continuing skin surveillance screening every 6 months, right? And this is typically performed by your dermatologist. And the fact of the matter is your skin cancer risk has not increased once you've had one skin cancer. All it is that, your original risk factors for skin cancer are still there, right? But what has happened now is your dermatologist or the person who's screening you now knows what a skin cancer looks like on your body or what looks like a concerning skin lesion. So they're more inclined to biopsy it earlier. And remember, in cancer, the typical thing is the earlier the diagnosis, the more likely we can cure it and the more likely we can treat it without creating a bigger scar or a bigger problem or more therapy or any of those things. So when should you come see us, right? So let's say, God forbid you have a concerning skin lesion, right? Obviously, the typical approach is you say, okay, let me be evaluated by my dermatologist, right? But let's say you don't have a dermatologist. Let's say, or your dermatologist is booking out until October. It's not a good idea to just be sitting there for 2-3 months with a concerning skin lesion, especially if it's a melanoma or a mole or a Merkel cell that's just kind of sitting there. It's probably not the best thing. So the next step would be to say, if you can't get an early appointment with your dermatologist, go see your primary care doctor. See if they can look at the lesion and decide, okay, no, this does need referral out, or if they want to biopsy it, have them do it. And many times a PCP will then refer you to a surgeon for a biopsy or to, another dermatologist who may be available to do biopsies. And the last resort, would be that, okay, you can't reach your PCP or you don't have a PCP, you don't have a dermatologist, you have a really concerning skin lesion that has been getting worse, and you could come in to see me, in that case scenario, I can come and look at these concerning skin lesions and we can biopsy it if it's necessary. But I don't want patients to forget about these things and say like, oh, well, I couldn't get an appointment for 3 months, whatever, I'll just wait. It's fine. It's probably not a big deal. That sometimes can become a problem because, again, early diagnosis and early treatment leads to more beneficial outcomes and allows you to have cure of any of these things. But again, biggest thing about all of this is make sure you're protecting your body against the sun, and making sure you understand that if you do have a skin lesion, which many times is not diagnosed by you, right? It's typically by your partner, by your husband, by your wife, by your kids, by your coworker who will see you every day and say, hey, something looks weird on your neck, or hey, something looks weird on your arm, or I see that thing on your back, something looks really weird. Take that with important understanding, because people just don't tell you that things look weird for no reason. So just be aware of that and make sure that you are pretty up to date and having skin screening evaluations, and that you are taking steps to reducing your risk for this potentially to spread and potentially to create more problems. But I wanted to thank you guys for giving me the time to talk, and we'll take any questions about anything.
That was great information. Thank you so much, Dr. Kadri. We do have some questions coming in here, so we'll go ahead and jump right into that. First, let's start. Where do most skin cancers start? And are there any like warning signs of it, like before you see that suspicious looking lesion?
Yeah, so typically skin cancers are almost always there in the epidermal layer, right? We went over those cells that are there, but they will be in any area that you have a sun exposure to, right? And there are melanomas that are not in significantly sun exposed areas, like your lower back, which might not get a lot of sun, or your buttocks, or areas that really are not typically exposed to sun. So in reality, skin cancer can unfortunately happen everywhere, right? And there's another question I can see. It can even happen. The question is, what would you do if you have a dark line on your toenail or fingernail? So subungual melanoma or subungual lesions, right, can be benign, right? They can be, lesions that are just like a hematoma or something concerning. But many times, especially if something has been there or it looks like it's getting worse or broadening, they can be benign moles that are underneath the nail bed. But at the same time, if it looks like it's getting worse or changing, you do want to have that evaluated to potentially have a biopsy of that area. So even subungual lesions, which means underneath the nail bed or underneath certain areas, or even mucosal, which would be inside of the face, those are all areas that should be evaluated for, any changes or any concerning lesions should be evaluated by either a primary care doctor, dermatologist, or by a surgical oncologist. We have another question. I had radiation treatment to my face. My skin looks great. So essentially the question is, patients asking, they've had radiation to their face, skin looks good, they want to avoid preventing sun damage. They understand the sunscreen lasts about 80 minutes, and we typically say reapply every 2 hours. She also uses a mask and a hat. Again, she's saying how strict should I be about sun exposure, right? And she does have an increased risk for having skin cancer, especially if she's had radiation to the face, and that at the same time, right, if she's fair skinned, then or he or she is fair skinned, then they do have an increased risk for skin cancer. Now, I don't want to say that you have to act like a vampire and stay indoors all the time, but I would say that it is important to actively protect your skin against significant amounts of sun exposure. Like 5 minutes would probably be okay. Maybe don't go with the 15 minutes that may be recommended for that. And then maybe supplement your diet with some vitamin D or take a supplement in those situations. Just because you do have an increased risk for having skin cancer, you wouldn't want to push your body into having that increased risk for something that might be avoidable. So I would say, obviously don't limit your social activities to say like if you're, there's like a big fair or something and you want to go out with people or hang out with them, don't say I can't go out with them. Just make sure you bring sunscreen, make sure you bring a hat. And if you do need to take off your hat and you go on a roller coaster or something, so be it. Like a couple of minutes of sun exposure are not going to create problems. It's the cumulative effect, right? If you think about things, it's not just one instance of a problem happening, right? It's like it happening over years and years and years of damage. So, obviously don't don't mess up your social life, don't mess up all of these things with this, because we are human beings. We back in the day didn't have houses to live in. We lived outside, we had sun all the time. So it is important to understand that you can live your life normally, just take extra precautions when you can and when are necessary to protect yourself against the sun. Besides the look of skin, Can irritation, itching, or pain, can it be an indication? So any one of those things, unfortunately, can be an indication for skin cancer, right? Like itching, inflammation, pain, any of those things could be a trigger for skin cancer, unfortunately. And it is always difficult. Like you probably saw some of those pictures. Every one of those skin lesions looks the same, right? And when you look at an non-pigmented melanoma, you'll say, oh, that's probably a squamous cell carcinoma. When it comes back as a melanoma, I'm always surprised because I say, well, there goes another one that's an apigmented melanoma. So again, if there is a concerning lesion that you have that's causing itching or pain, it doesn't necessarily have to be associated with it. They can also be lesions that are not doing anything to you, but are just growing or look the same. Have it evaluated. It's always safer to have an evaluation and have somebody have a documentation of it. They might say, hey, it looks okay right now. Let me take a picture of it. And then when you come back in 6 months, I'll look at it. And if it looks like it's changed, we'll remove it. But if it doesn't look concerning, that may be the next best step. And next, are there skin cancers that can present as rashes that migrate around different parts of bodies? Now, again, skin cancer can happen everywhere, right? Typically, a rash is going to be different from a skin cancer itself. A skin cancer will be there for longer periods of time and probably will not change. There are only things that I would say, like if you were to say, okay, I've had this lesion on my arm that's been there for, a couple of months and it looks like it's getting worse. That to me is more concerning than, let's say you have a rash in that area every time you eat like cashews or something, right? You're allergic to nuts, right? You eat cashews and you've got a rash that develops in that area too, but it completely goes away. So that to me would not make me as concerned for it to be a skin cancer. It's got to be something that stays consistent and doesn't go back and forth like a rash. And then let's see, I've been diagnosed with cutaneous T-cell lymphoma, being treated with UVB phototherapy. What's your thought on this? I was told this is not the type of cancer that will kill me. In these situations, right, you do need to treat this T-cell lymphoma. And while there are risks with the narrowband UV phototherapy, the lymphoma itself treatment outweighs those risks of undergoing the phototherapy. So I would say in those situations, I would follow, treatment of your lymphoma rather than worrying about the skin cancer. Because as you see, right, your increased risk of this, while you could have a melanoma, God forbid, or a Merkel cell carcinoma, a basal cell and squamous cell carcinoma, you're going to live 99% of the time in 5 years, right? It's typically not going to kill you. So I would say treat your lymphoma with UVB therapy. That's fine. That's going to be more important to treat than taking on the risk of having a little bit of skin cancer from it. And then do you protect yourself against UV radiation even during the fall, spring, winter months, even when it's not too warm? Yeah, it is important to understand that depending upon where you live, also in the equator, right? Where we live, like people who are more on the equator line, obviously are going to have stronger sun. It's going to be longer. It's going to be more aggressive. And again, in the winter, the timing of light is a lot less. All of these things are components. I would say I wouldn't change the way I approach my skin protection methods. I do the same in the winter. I do the same in the summer. It doesn't really matter, right, to me, right? While you might have less sun exposure in the winter because you're indoors more frequently and that you may not even get enough sun, I say it's always safe to approach both, in the same way, because it makes it easier that way. Because then you say like, okay, well, in the winter, I'm not going to wear my big hat. I'm only going to wear my short hat, or I'm not going to wear a hat in the winter. To me, that becomes a little bit difficult because you're not staying consistent, because UV radiation is there still, even in the winter or even in different locations. And so again, I would say the more you're consistent, the easier it is for you. And it's just less to think about, right, in a day, because again, it's better you protect yourself rather than not protect yourself or change your routine than, you're just saying like, you know what, maybe I don't need to protect myself in the winter. And then summer starts creeping in and then it's June and you're like, oh, I forgot to put on sunscreen for like these couple months that it was really sunny. That makes it a little bit, more difficult for me, at least for me. That's why I look at it.
And just to add to that, Dr. Kadri, if you're at, on a weekend at a football game or a sporting event, a family outing, and even though it might be 40, 50, 60 degrees and you're not in shorts and a tank top, you're in, long sleeve clothes, your face, your neck, there's still sun exposed areas. So it's still good to put on sunscreen and do good sun protection because you're still exposed to it, even though it's not warmer.
Yeah, absolutely. 100%.
What would you guys recommend as far as like cloud cover goes? Is that the same as like if it's not as warm out that day, can you still get sunburned when it's cloudy?
So, obviously there is some blockage of, UVA rays that are coming from there and UVB from the clouds. But at the same time, you never know if the clouds are going to go away, and maybe it might be a true overcast day. The way I do it is just be simple, right? Every day do the same thing, right? It doesn't matter if it's raining that day. It doesn't matter if it's doing anything. You never know if when you leave for the evening, right, there's no more rain, there's sun out there, and you're going to go out with your colleagues at work, and now you're out in the sun and you're not protected, right? I would say keep the same routine so that you're not like caught in a situation where you're having unprotected sun exposure and it's happening over and over and over again. Yeah, if it happens once or twice, like so be it. That's okay, right? We have to live our life, right? But don't let it happen consistently where you're constantly not protecting your sun and your skin from the sun, and it turns into a problem. Can you get adequate vitamin D from early morning and late evening sun when the sun is not as strong? Yeah, there are some studies that say, so this basically is saying, can you get enough vitamin D if you're in the non-peak sun periods where you're not between 10 a.m. and 4 p.m. There is some data that suggests that you do need to be out in the sun longer. Like there's one thing that said, if you're in Boston in the winter, you need to be out for 23 minutes instead of 15 minutes, or you need to be out for a little bit longer. I would say make it somewhat consistent, right? When you're going out there, like maybe in the winter you could go out like 5 times, right? And in the summer you only go out 3 or 4 times. But I would still suggest that even the early morning sun and evening sun is probably better in shorter doses, but more frequent than like going out in the blazing middle period of the sun and having that increased risk, because you don't really know exactly how much sun exposure you're getting when it's unprotected. And so I would say still apply that, maybe say 15 minutes early morning, but do it more frequently in the winter, rather than saying like, oh, well, this sun isn't adequate enough, so I'm going to stay out for 40 minutes out there in the sun. I think being more consistent is better than, changing things up all the time. I think that's when you fall into these pitfalls of like not realizing what you were doing or what you weren't doing to protect yourself against the sun. Are all sunscreens either oxybenzone or mineral based? There are some other options that typically they're mineral based because it's the easiest thing. There are some options. Some people say, like, I think beef tallow is another thing that's getting into it, but they do all have components of something that should be a protectant, right? So you'll look at hats, and the hats will say like SPF 50 or 60, right? All it is clothing that's protecting your body against the sun, right? So really what SPF is just what is blocking those rays onto your body. So you do need something to block those rays. And whether it's in the form of some other chemical or something else, typically these mineral sunscreens are natural. So that's why I would say it's probably best to go with those. But yeah, you do need something that's blocking the sun from that region. And typically your oxybenzone based or mineral based ones are your gold standards that you'd have, because if not, you're going to be spending way too much money for weird experimental stuff that's there. And these are tried and true proven things that I think would be beneficial to use. I had a shave biopsy done. So I had a shave biopsy done. How do you know if residual cells are in regression? That's the problem. You don't know, right? So essentially this question is asking, the patient had a shave biopsy done. Their cells that are, the margins were likely positive. Do you know if the cells are regressing? Are you having spontaneous regression? You unfortunately don't know that, right? You just know that the cells were positive, that were there, and that now the next steps in treatment are either you remove the thing or you watch it, right? And I would say in my experience, about 30% of the time, patients have spontaneous regression, which, the tumor is not even there on the final pathology after we excise it. But to me, that gives you peace of mind to say like, okay, well, thank God my body killed it. There's no more residual cancer. Great, right? It's better to have that than to say, oh, I had some residual cancer and it started growing again and started, God forbid, spreading into other areas and created problems. To me, that seems much worse than not removing it. But again, this is a discussion with every patient to say like, look, if you have a lot of other medical problems or comorbidities, you are going on a trip, right? A trip you've been waiting for to go I don't know where, right? To like Bali or somewhere, right? And you're like, I'm gonna go swimming, I'm gonna do all this stuff. And if I have a skin graft, there's no way I can go swimming with that. I would say let's not mess up your trip. Let's go on your trip, especially if you have squamous or basal cell carcinoma. Go on your trip and then we'll evaluate it when you come back, right? It's not an end all be all for a lot of this stuff. A lot of it's kind of dynamic discussion with every patient, and every patient is different.
That's great. Looks like that is the end of our questions for this evening.
Okay.
All right. So if anyone thinks of any additional questions or you'd like to get more information, the number for Ascension St. Agnes Maryland Surgeons, that's Dr. Kadri and Jessica's office, is on the screen now. That's 443-574-8500. Or you can also find more information on ascension.org.